Now I will be proceed the assessment segment 2, the thorax with respiratory function. The first, we observe the patient respiration. The respiration should be regular and symmetrical, and the accessory muscles should not be used. The patient should be able to breathe comfortably while sitting his arm at the rest. Next, I'll be moving slowly to the back to assist the anterior, posterior, and the lateral dimensions of the diameter of the thorax. Normally, the lateral diameter is up to twice the anterior-posterior diameter for a ratio of about 2:1. We will palpate of the spinous processes using the finger pads. Palpate the back, and the spinous processes should be evenly spaced and non-tender. Next, we assess the respiratory expansion. To do what, we place both of our thumb in the T10 or in the level of the 10th thoracic vertebra. Thumbs with our hand center of the back, and lead the patient to take a deep, slowly breath.
Uy!
Normally finding is that the thumbs more symmetrically. Next, we proceed to tactile primitus, or the voice sounds palpated on the chest walls surface using the ball of the hand to detect for the vibrations. We move from the 8 pieces inside the sepals down to the lower and lateral thorax. I place my hand to your back and repeat the press 99 as I move my hand.
99. 99.
The normal findings that we should able to feel equal vibration in each location. Next, we perform medial percussion using a systematic pattern. Recovery runs should be heard equally in the lungs. We can hear dullness over the diaphragm. Hyperresonance indicates that we find an area at increased air in the lungs or in the pleural space. However, abnormal dullness indicates decreased air in the lungs. Next, we assess the diaphragmatic execution. To do this, we instruct the patient to exhale and hold his breath so we can percast from the scapula down to where the sound changes from resonance to dullness. Sir, please exhale and hold your breath in. We will be instructing the patient to inhale deeply and hold his breath as we percast further down where we will find a new area of dullness. Please, sir, inhale deeply and hold your breath. Palpate the back mark with a pen. We will repeat the process to the other side. Please exhale again, sir. Using the tape measure, we'll be measuring the distance of each side. Measure the distance. The distance indicates diaphragmatic exposure. Normally, the distance measured from 3 to 5 cm and must be equal both sides. Next, we assess fire kidneys using the blunt or piece percussion over the cause of the vertebral angle. Hand to the back and percuss with other hand, blunt hand. Percussion in this area should not tenderness. While consulting the breath sounds using the diaphragm of the stethoscope starting at the lungs. F. Be sure to listen at the last one complete respiration and each location. Please, sir, to deep breath deeply through your mouth. Normal breath sounds may vary on the area you are assessing. Broncho-vesicular sounds may be heard between the scapulae, which have an inspiratory phase equals to expiratory phase, and vesicular sounds may be heard in F's down to the bases and laterally, which have an inspiratory phase longer than exploratory phase, and we listen for abnormal breath sounds which
Ano sa kuan kayo? 8 minutes na.
15, pwede man 15. Gamay na naman.
Basta din mo plapas o kuan. Dugay mo ba pasa.
Ari na sa top. Ang diaphragm ulit sa center. Sakto ra to.
Tura kong tubo.
Broncho-vesicular sounds may be heard between the scapulae, which have an inspiratory phase equal to expiratory phase, and then vesicular sounds may be heard at the apices down to the bases and laterally, which have an inspiratory phase longer than expiratory phase. And then we listen for abnormal breath sounds, which are crackles and wheezes.
Paasa yan. Pa-perform ako ha. Papa naman na siya doon. Sa'yo naman na kayo. Sakay sa ako makalimot ko permanente.
Kaya di man pwede bayan ako kaya namin dapat si Tutoy.
Mujud. So, wag mo ra tag tutoy ano daw?
So crackles
Brara din dala.
Pag video may ang sige sa'yo.
O dala.
Bayot na natin ang teacher.
open. If you heard crackles, you have to instruct the patient to cough and then listen again to determine if the crackles have been cleared. Sir, okay, I want you to cough. Now, wheezes, which may be heard during inspiration or expiration, are caused by obstruction in the airway, or it may be caused by narrowing or swelling of the airway. Now, if you suspect for an abnormality, you have
Day, ihunong ko diri sa ko anday o sa kanang airway ha.
Asa airway?
Dara ay caused by
Ah,
Norway.
ah, ah. Wait, asa?
Norway.
Norway. Asa ba ay?
Tra airway oh.
Airway.
May be caused by narrowing or swelling at the airway?
Oh,
Mora? Wala to ilabot if we notice?
wala pa. Tabi sa diha, David.
Airway. Eh, ano sa?
My love. If we notice If we notice abnormality, we access further using consultation by having the patient and see 99 that they have abnormality.
$99. $99.
Normally, the sounds created are muffled and indistinct. Next, assessing the patient anterior thorax start with bones and muscles. Normally, it should be symmetrical and accent and accessory muscles use restrictiveness or bulge. The patient should not show sign of respiratory difficulty such as a sinuses or nostril flaring. Next, the palpate to thorax with the finger pads from lung, apices, and the bases. It is simple, sir.
No.
Normally should not feel tenderness or nodules. Next, assist the respiratory expansion, so I will place hand to the patient chest along costal margin with both of my thumb pointing towards the side-pod process. Ginawa, sir. In this assessment, we observe our thumb because normally the thumb should move simultaneously and symmetrically upon respiration. And next, we assess the tactile primitus and the anterior thorax. I tell the patient to repeat the pieces 99 up to down using thumb. Normally, you feel equal over vibration on the both sides. However, stronger vibration should be felt on the upper chest than the lower chest. Next, I will use percussion over the lungs using a systematic approach. Percussion this area produces two resonant sounds. Next, I will auscultate over the patient lung with the diaphragm of a stethoscope using the same pattern that we use in the percussion, then listen for at least one normal respiration at each location. Normally, sounds may vary in the area you are assessing. You must hear tracheal sounds over the trachea, which are high-pitched and tubular, and also hear the bronchial vesicular over the thorax and the respiratory. Then you feel abnormalities, should assess the further by seeing the patient 99 several times as we consultate the area that the involved 99.
Ninety-nine. 99. 99. 99.
The normal finding is that the sound that will be produced should be muffled and indistinct. And lastly, document the findings.